Hey, today's lesson is about part 1 of congenital heart disease. To start from the epidemiology of congenital heart disease occurs in 0.5 to 0.8% of live births, and the incidence is higher in those who have spontaneous abortus, stillborn, and premature infants. It's estimated to occur in 10 to 25% of spontaneous abortus, and it is thought to occur in 3 to 4% of stillborn newborns and about 2% of premature infants by excluding PDA. When we see the relative frequency of congenital heart disease, the most common congenital heart disease is ventricular septal defect. This is followed by atrial septal defect and the patent ductus arteriosus. And the ventricular septal defect is thought to be responsible for 30 to 35% of all congenital heart disease. And this is followed by coarctation of aorta, tetralogy of Fallot, pulmonary valve stenosis, aortic valve stenosis, and there are also congenital heart disease which is rare: hypoplastic left heart syndrome, hypoplastic right ventricle, truncus arteriosus, total anomalous pulmonary venous return, tricuspid atresia, and double outlet right ventricle, and others. Those are rare and they are responsible for 1 to 2% of congenital. Most congenital defects are well tolerated in the fetus because of the parallel nature of the fetal circulation, except Epstein anomaly. Even the most severe cardiac defects, for example, hypoplastic left heart syndrome, can usually be well compensated for by the fetal parallel circulation. And the congenital heart disease becomes apparent after birth when the fetal pathway is closed. When we see the time of presentation, it is dependent on the type of the congenital heart defect. For example, those that present at birth include critical semilunar valve stenosis, hypoplastic left heart syndrome, and detransposition with no shunt lesion, and they present with severe respiratory distress at birth. And most left to right shunt lesion presents at 6 to 8 weeks of life, and when the pulmonary vascular resistance decreases to less than the systemic pressure, and the symptomatology depends on the degree of the shunt. When we see dynamics of congenital heart disease, the severity of various defects can change dramatically with growth. For example, muscular ventricular septal defect becomes smaller or it might close spontaneously as the child grows. And semilunar valve stenosis, mild in the newborn period, may become worse if valve orifice grows and it does not keep pace with a patient's growth. So some might get some improvement and even they might close, whereas some congenital disease might become worse as the time goes. When we see the etiology of congenital heart disease, congenital heart disease etiology is multifactorial. Some hereditary and familial contribution can be there. Chromosomal abnormality might also contribute for congenital heart disease, and also teratogenic factors, environmental and maternal drug use can also contribute to the development of congenital heart disease. So overall, CHD is multifactorial. Heart disease is found in more than 90% of patients with trisomy 80, and it is present in 50% of patients with trisomy 21 and 40% of those with Turner syndrome. So in this case, we see that it is associated with some chromosomal abnormality. To see certain environmental risk factors for congenital heart disease, 2 to 4% of congenital heart disease have certain environmental risks. They include, for example, adverse maternal conditions such as maternal diabetes mellitus, maternal SLE, phenylketonuria, and also teratogenic influences such as congenital rubella syndrome, maternal ingestion of drugs such as lithium, ethanol, warfarin, and the like. And when we see the gender difference, transposition of great arteries and the left-sided obstructive lesions are slightly more common in boys, whereas shunt lesions and the pulmonic stenosis are more common in girls. And there is no racial difference in congenital heart disease prevalence. The risk of recurrence of congenital heart disease increases if a first-degree relative is affected. So if one first-degree relative is affected, the risk is around 2 to 6%, and if two first-degree relatives are affected, the risk might reach up to 20 to 30%. When a second child is found to have congenital heart disease, it will tend to be of similar class as the lesion in their first-degree relative. and the degree of severity and the associated defects might be variable. When we see the basis of classification of congenital heart disease, we can classify congenital heart disease by the presence or absence of cyanosis, by the presence and the character of murmur, and also based on chest X-ray finding. Some congenital heart disease present with increased pulmonary vascular marking, whereas some present with normal pulmonary vascular marking, and the other might have decreased pulmonary vascular marking on chest X-ray. So this helps us on classification of congenital heart disease. And the other is ECG finding, right, left, or biventricular hypertrophy is used to classify congenital heart disease into two types. The other is from the cyanotic congenital heart disease. When we see the dynamic changes of certain congenital heart disease, intracardiac defects may grow smaller with time, and the pulmonary vascular resistance decreases to normal adult levels by several weeks of life, and patients with shunt lesions become symptomatic. And the chronic exposure of the pulmonary circulation to high pressure and the blood flow results in a gradual increase in pulmonary vascular resistance, or Eisenmenger physiology, with a shunt. When we classify congenital heart disease based on dynamics, there are lesions that results in increased pressure load. From this, pulmonic stenosis, aortic stenosis, coarctation of aorta, and tricuspid stenosis are the most common one. Whereas cyanotic congenital heart disease include lesions with decreased pulmonary blood flow and the lesion with increased pulmonary blood flow. From those lesions with decreased pulmonary blood flow, tetralogy of Fallot, pulmonary atresia with intact septum, tricuspid atresia, total anomalous pulmonary venous return with obstructions are lesions with decreased pulmonary blood flow that cause cyanotic CHD. Whereas cyanotic CHD with increased pulmonary blood flow include transposition of great vessels, single ventricle, truncus arteriosus, and the total anomalous pulmonary venous return without obstruction. Cyanosis with decreased pulmonary blood flow, and cyanosis caused by obstruction to pulmonary blood flow with right to left shunt of venous blood, and the degree of cyanosis depends on the degree of obstruction to the pulmonary blood flow. Cyanosis caused by abnormal ventricular arterial connection, such as transposition of the great vessels, and it might be due to total mixing of systemic venous and the pulmonary venous blood within the heart, such as a common atrium or ventricle, total anomalous pulmonary venous return, or truncus arteriosus. Thank you for your attention. The next part, or part 2 of congenital heart disease, will be released after a few days. Thank you for your attention, and don't forget to subscribe.